All right, so we are good. Good evening, everyone. Thank you all for tuning in tonight to what hopefully will be a very informative and interesting discussion. My name is Miguel Trejo, and I serve as a Community Relations Assistant with the Community Council of Greater Dallas. Just to provide a brief overview of who we are, Community Council has been serving the Dallas area for over 80 years, and our mission is to improve the quality of life of individuals by alleviating poverty, fostering independence and wellness, and connecting people to the resources they need. I'm so excited to introduce the topic for today's event, which is especially important in today's day and age. Community Council and TSU, partnering alongside the All of Us research program, would like to welcome you all to tonight's conversation on medical mistrust and vaccine hesitancy in the era of COVID-19. Now, to kick things off, it is my pleasure to introduce you to one of our amazing panelists, Paula Johnson. Paula is the Bureau Chief for the Harris County Area Agency on Aging, assisting the elderly and their families with options that promote independence, well-being, and dignity. Paula served as a public health analyst with the Centers for Disease Control and Prevention. She also served as a team lead for the Ebola Policy Unit, deputy team lead for the Zika, and acting director for the Policy Unit for the Division of Emergency Operations. She is also a proud veteran, having served 27 years in the United States Army, achieving the rank of Sergeant Major. With all that being said, Paula, please take it away.
All right, thank you, Miguel. And so I would like to, our moderator, and so Dr. Flora Estes is an associate professor of pharmacy practice, in which she coordinates and teaches pharmacy practice courses to first-year students, which includes APHA immunization certification, AHA CPR BLS certification, and dispensing of medication. Second-year students on non-prescription products, and third-year pharmacotherapy courses. Additionally, she precepts both introductory pharmacy practice experiences and advanced pharmacy practice experiences students on academic drug information, clinical, and international elective rotations. Dr. Estes also assists in the coordination of continuing pharmacy education development activities for courses in the development of pharmacy practice and administrative services. She is actively involved in national organizations such as American Association of Colleges of Pharmacy, Special Interest Groups, American Pharmacists Association, Immunization Delivery, Faculty Advisor for Phi Lambda Sigma, Pharmacy Leadership Society. She serves on the Texas Southern University Faculty Senate, a University Comments Marshal, and as an advisory board member for Houston Community College Coleman College Pharmacy Technician Program. Dr. Estes' research interest and involvement is with maternal and child health, minority health research and education, polycystic kidney disease, pediatric hypertension, and she initiated a collaborative clinical pharmacy assistant program for pharmacy students. She is a 2002 graduate of Texas Southern University. She completed her residency in drug information, and she has continued to service TSU for 18 years. Dr. Estes was introduced to the All of Us research program by Jessica Walker of the Community Council of Greater Dallas. When presented with the opportunity for Texas Southern University, one of the largest HBCUs in the country, to be able to share this information, Dr. Estes sees the opportunity to share this information with others and in this community forum. I'd like to turn it over to the Associate Professor, Dr. Flora Estes.
Thank you, Paula, for that introduction. I really appreciate it. So, greeting to all of our online audience. Thank you for taking a moment to be with us this evening as we explore medical mistrust and vaccine hesitancy in the minority community. A quick shout out to Dr. Rashid Mosavin, who is the Dean of the College of Pharmacy and Health Sciences, and also to our president, Dr. Alicia Crumpton-Young, who for their support of this program this evening. So before I introduce our speakers for this evening, just a few housekeeping notes that we will have a poll, a survey in the chat later on toward the end of our program. So we really would like for you to take a moment to complete the poll. is just to help us gather some demographic information. Since we are speaking to minority communities, we really would like to know what communities we have online with us. And because we also did a push to get as many of our students involved in online, we're looking at that age group as well. So just take a minute to fill out the poll and give us a overall about the quality of the program, how it has benefited you overall. So with that being said, I would like to move to introduce our panel of speakers for this evening. So we have first Ms. Zuri Dale. Ms. Dale earned a Bachelor of Science degree in biology from Texas Southern University in 2011. Also a Master's of Water Management and Hydrologic Science in 2014, along with a Master's of Public Health and Epidemiology, both from the Texas A&M. She is continuing her academic training by pursuing a doctorate in public health from Mercer University. Zuri interned and conducted research at numerous institutions, including but not limited to NASA, the CDC, and the Texas Parks and Wildlife. Zuri has distinguished herself as both a scientist and a scholar. She's participated in numerous research projects and earned numerous awards. She returned to TSU to serve as the university's infectious disease epidemiologist and public health scientist. Her scientific work places special emphasis in the epidemiologies of SARS-CoV-2. Zuri has held several teaching assignments at both Texas Southern University and also at Princeton University, and she holds a biostatistics of public health specialization from Johns Hopkins University. She's a current member of the American Public Health Association. She's the director of the TSU COVID Prevention Center and serves as the Texas Southern University COVID czar. Through the COVID Prevention Center and under Zuri's direct leadership, TSU has developed a robust COVID response program that includes clinical testing, laboratory analysis, genetic sequencing, vaccination opportunities, and an air and water quality monitoring. So thank you, Ms. Dale, for being with us this evening. Our other guest speaker is Attorney James Douglas. Dr. Douglas was born in Onalaska, Texas. He grew up in North Houston and graduated from Kashmere High School. He graduated from Texas Southern University in 1966, receiving a Bachelor of Arts in Mathematics. He earned his Juris Doctorate degree in May 1970 from the Thurgood Marshall School of Law at Texas Southern University. He continues his legal studies at Stanford University School of Law, where he received a JSM degree in computer law in 1971. He began his professional career with Singer General Precision, which was part of NASA, where he was the computer analyst assigned to the Lunar Module Mission Simulator. Dr. Douglas began his teaching career as an assistant professor of law at Texas Southern University, where he taught the first course in computer law that was offered in American legal education. He became the 17th in the history of Thurgood Marshall School of Law. He was appointed interim provost and vice president of academic affairs, and he became the 9th president of Texas Southern University. After his term as president, he returned back to the legal education, where he became the distinguished professor of law at the Thurgood Marshall School of Law. He serves or is currently serving as member of numerous boards. He has numerous accomplishments, and he's dedicated his life to the continued legal education of students from all ethnic backgrounds. We welcome Dr. James Douglas, Esquire. So next we have Dr. Pamela Gobina. She's originally from Dallas, but she currently resides in the Rio Grande Valley. Dr. Gobina earned her Bachelor of Science degree in psychology from the University of Houston in 2003. She earned her Doctor of Pharmacy degree from Texas Southern University in 2007 and completed her pharmacy practice residency with a concentration in pediatric and adult medicine from Christus Santa Rosa in San Antonio. She was the director of pharmacy at Solera Specialty Hospital in the Rio Grande Valley area for 11 years, moving into medical affairs and eventually joining Moderna as a medical science liaison that's covering Texas. Her therapeutic area of expertise is vaccines, specifically with COVID-19. And she's been with Moderna since 2021. Welcome, Dr. Gobina. Our next guest is Gwendolyn M. Goins. Gwen is employed as a senior community liaison in the Office of Chronic Disease, Health Education, and Wellness at the Houston Health Department. She also serves her community through Sigma Gamma Rho sorority as the National All of Us Program Coordinator. She also is a representative on the Black Greek Letter Consortium, which is an avid partner of the All of Us Research Program. She attended UT at Austin, later transferring to the University of Houston, where she earned her Bachelor of Science degree in professional writing. Her professional work in public service began in 2005 when she joined the City of Houston to work in Mayor Bill White's office as a correspondence coordinator. She was initially hired by the Houston Health Department as part of their COVID response team, but her responsibilities has led her to be the program development for the Project First Line, a CDC-led infection prevention and control training initiative. She also manages stakeholder relations, partnership engagement, and is a content contributor of the communications and marketing team. So welcome, Ms. Goins. Dr. Rodney Hunter is a clinical associate professor at Texas Southern University. He is a clinical pharmacy specialist in breast medical oncology at the UT Health Memorial Hermann Cancer Center. He has served as the program director of the TSU Breast Cancer Screening and Prevention Center that's funded by Susan G. Komen. He actively works with the Center for Biomedical and Minority Health Research at TSU on research projects and community outreach initiatives. He is also a clinical assistant professor in the Division of Internal Medicine, Department of Oncology, at the UT Health McGovern Medical School in Houston, Texas. Dr. Hunter obtained the Doctor of Pharmacy degree from Texas Southern in 2007. He went on to complete an oncology fellowship at the UT MD Anderson Cancer Center in Houston, Texas. Welcome, Dr. Hunter. Dr. Heather Kitzman. Dr. Kitzman is the research director at Baylor Scott and White Health and Wellness Center, which is a primary care medical home and population health entity of Baylor Scott and White Health, which is the largest nonprofit healthcare system in Texas. She is also an associate clinical professor of health service research at the Robbins Institute for Health Policy and Leadership at Baylor University. Dr. Kitzman obtained her master's degree in family therapy from UH Clear Lake, a bachelor's in psychology from UT Austin, and her master's and doctorate degree in psychology from Southern Methodist University in Dallas. She conducts healthcare services research on health disparities that's related to cardiovascular disease, diabetes, kidney disease. Baylor, Scott, and White is also the site for All of Us, which is the largest study conducted by NIH to evaluate precision medicine innovations. Their research uses community participatory approaches and aim to develop innovative and cost-effective approaches to improve both patient-related and healthcare systems outcomes. So welcome, Dr. Kitzman. Last but not least, we have Dr. Courtney L. Walker. Dr. Walker is the Medical Accounts Director at Novo Nordisk, Inc. for the Texas, Louisiana, North, and New Mexico region, specializing in diabetes and obesity. In his role, he spent time consulting health plans and state government organizations such as Medicaid, Medicare, looking for drug formulary decisions impacting millions of patients throughout the country. Additionally, Dr. Walker engages with large companies such as BP, British Petroleum, Southwest Airlines, AT&T, U.S. Steel, who are attentive to the clinical crisis of obesity and diabetes in their employees. His aim is to assist these companies with the improvement of their employees' health via proper medical management. He's a proud graduate of Texas Southern University College of Pharmacy and Health Sciences, where he earned his Doctor of Pharmacy degree. He completed a managed care pharmacy practice residency at Humana, Inc. in Louisville, Kentucky. Dr. Walker worked 5 years as Senior Outcomes Liaison for Eli Lilly, specializing in mental health and diabetes medication. 4 years at Johnson & Johnson as Senior Medical Liaison, specializing in rheumatology, dermatology, gastroenterology, oncology, and autoimmune disorders. He's completed more than 17 years of pharmaceutical industry experience and has given hundreds of clinical presentations across the country. Most recently, Dr. Walker has served as an expert on panels for AT&T and Southwest Airlines on the prevention of prediabetes and diabetes in the employer environment. He was also a moderator at the 2018 Congressional Black Caucus in Washington, D.C., leading a discussion on diabetes awareness in the African American community. So welcome to all of our speakers for this evening. Thank you for being with us. So we will move on to our discussion for this evening. So I would first like to, our discussion that we're looking at, it starts off with medical mistrust. And I believe that medical mistrust is the underlying factor for a lot of the health disparities and things that we see within our communities, all of our minority communities. And so I think it will be a good understanding just to see what is medical, how do we define medical mistrust? So I would like to reach out to Dr. Douglas to share with us the definition, give us a framework of what medical mistrust, what does that mean?
Generally, when we're talking about medical mistrust, we're talking about an absence of trust in our healthcare providers. It might be our physician, it might be the doctor, it might be the nurse, but we generally think that, and it's not just medicine, it's mistrust in the person who's providing the health care for the individual. And so if you don't have trust in the person who's providing your health care, then you're more than likely not to accept their advice. And so when we talk about medical mistrust, especially on the parts of African Americans and other minorities, we know that that because of racism, because of a lot of things that have happened in this country, that a lot of minorities, especially African Americans, don't trust the system to provide the kind of health care that we should be accustomed to in this country.
Okay, thank you, Dr. Douglas. So we have negative beliefs about the intent of those providers, about the medical personnel that's trying to provide that treatment. So based upon that definition, can you give us maybe a historical perspective why medical mistrust, why it exists?
Well, I think when you talk to most African Americans will refer back to either to the Tuskegee experiment, where we know, based on information, that this is the one time where they use African Americans as guinea pigs to test the effect of drugs and syphilis on African Americans. And so it wasn't, and this test ran for decades before it was uncovered that we were using African Americans as guinea pigs. Then the examples like Bessie Smith, it is rumored that she was killed in an automobile accident and that she did not get the proper treatment. So whether it's true or not, most African Americans believe that it's true because of what was happening to African Americans at that time in terms of getting the proper treatment, being admitted to any hospital in the country, and being transported by people in ambulances that cared about your well-being. So a lot of this had to do with discrimination, and we can look at the results of discrimination in terms of the disproportionately poor health that African Americans have because of discrimination, whether it's high blood pressure, whether it's stress, and all of that leads to not believing in the healthcare system that this country provides for us.
Thank you. So, Ms. Johnson and Ms. Goins, so the population that you serve with the Houston and Harris County area, so do you see mistrust as a factor in the patients that you provide service to? Especially if you're elderly?
I'll go first. So our services that we provide, services such as home delivered meals, congregate meals, in-home services, caregiver, and other supportive services such as dental health and vision. We are the last funder of resort. So for those type of services, we do not see hesitancy, usually because other older adults have helped to spread the news that we do provide, those type of services. One thing that we are doing that we started last year was to start, we opened up a call center, expanded our call center because we realized that there was something missing for older adults and people with disabilities to be able to receive the COVID vaccine based on the priorities that were driven by the state. And we opened this up to allow our older adults to have access and to have equity to the vaccines. And that it was extremely successful. But what we do know is that as of January the 31st, that 88% of Harris County residents, I cover the entire county, with services age 60 and older are fully vaccinated. But when you break those numbers out by race, you will see that there are lower numbers in our African American community and our other minority communities. So answer to your question, we, during some of our sessions of educating our older adults about the All of Us initiative. And to talk about mistrust, we do know mistrust still, especially for older adults who, as Dr. Douglas was just mentioning, it's the history that is still there.
Okay, Gwen, do you have anything to share with us on that?
Yeah, I'll just add that, first of all, I think that because we are a city government providing services, that there's some general mistrust of government in our community. And so that's the first hurdle we really need to get over. And so what we've done in the Office of Chronic Disease, Health, Education, and Wellness, which we're really about educating the population so that they can make better decisions for their overall health. And so one of the strategies that we've used is in our image, just as we approach people, even though we work for a city government, we've really tried to work on that image that appeals to that grassroots, boots on the ground outreach initiative. So when we go into the community, we look like the community. We don't go in there with high heels and suits and ties. First of all, we address that image so that there's not that initial, wait, they don't belong here. It's the government, they're not on our side. And so that's why we have that boots on the ground, that going into the community, knocking doors, letting people know, hey, we're here, we have this information. And it has to be mistrust, the fact that these services that we offer for, all the health department, but specifically for health education, are free of charge. And so you've got to wonder, why are our classes being overrun?
Yeah.
Why aren't people tearing the door down? If they've got diabetes and we've got a nutrition and a diabetes wellness network, why aren't they beating down the doors to get in there? Because it doesn't cost them anything to do it. So there's definitely that medical mistrust that's the underlying theme of that. And so the strategies that we have, we try to be solution oriented to try to address that issue, because we know it exists.
Okay, thank you. And on that note, Dr. Walker, you have a background in pharmacoeconomics, and we know that medical mistrust, it is a health barrier, and there's all kinds of bad or worse outcomes that's associated with it. So can you kind of speak to your findings with regards to like diabetes and other conditions that's, pretty prevalent within the minority community?
Absolutely. So what we know is that inequalities in healthcare access and poverty have aided in the disproportionate way minorities have been affected by COVID-19, for example. African Americans are experiencing 2.6 times higher cases, 4.7 times higher hospitalization rates, and 2.1 times more death from COVID-19 compared to whites. We also know that diabetes, which is common in 10% of Blacks aged 35 to 49 compared to 6% whites. High blood pressure is common in 12% of Blacks versus 10% of whites aged 18 to 34, and then 33% in Blacks and 22% in whites aged 35 to 49. The same is true in regards to stroke as well, disproportionately high numbers in African Americans versus whites. These factors all lead to worse health outcomes for African Americans, leading to 20% more psychological distress, but 50% less likely to receive counseling or mental health treatment due to socioeconomic factors. So when you put all that together, certainly the numbers show that African Americans certainly are disproportionately affected. And so really it's encouraging to see there's more investment in the area of social determinants of health by health plans, state government. We have the social determinants of health caucus in our government, because now what COVID-19 did was really say, hey, we've got to focus on more vulnerable patient populations, of which we know African Americans certainly are.
Thank you. And as Gwen was just saying, that they're providing all of these resources, but we can't get people to take advantage of it. So these numbers continue to grow.
Yeah.
As you are, as you mentioned. So what can we do to try to overcome? You even talked about mental health. You know, it's one thing even just trying to get them in just to take care of basic needs, you know, blood pressure, again, diabetes, those kind of things. But even to discuss mental health,
Absolutely.
which we have really, I think everybody, the nation has faced, you know, in the era of COVID. So, you know, that's a whole nother, I guess, another topic by itself, just trying to get people to address that and not feeling the shame or stigma of reaching out for mental health support as well. So,
You know, oh, I'm
yeah,
sorry.
no, go ahead.
Okay. So Benjamin Franklin said an ounce of prevention is worth a pound of cure, right? So when you talk about mental health, we had a study that we just did on one of our products, and we compared patients who had never had counseling. We added counseling to their management of obesity, and those individuals fared better by 4%. We saw a 4 to 5% increase in the effectiveness just by adding intensive behavioral counseling. So we know that counseling is certainly needed. And as you mentioned, when you come out of what we've come out of, counseling could certainly benefit so many. And then when you talk about the understanding of disease, my passion is to help patients understand the nature of diseases like diabetes and obesity. When I grew up in the country, grandma called diabetes sugar, right? But
Right.
sugar diabetes, if sugar is also a word of endearment that you call your grandchildren. Oh, that's my sugar, you know. So that takes the sting off of a very serious disease. So what we have to continue to do is focus on how do we effectively educate. And one of the things that I do is when I talk about diabetes, I talk about the excess blood sugar in the bloodstream that over time leads to oxidation within the blood vessels, and that oxidation causes conditions very similarly to when bananas are green and they go through ripening, they oxidize. And when they oxidize, they turn brown. And what is the consistency of them? So I talk to patients, I say, what happens when a banana turns brown and you press it? Well, it breaks. They said it gets squishy. And I said, that's the same thing that happens in your blood vessels. And it happens first in the kidneys because they're small blood vessels. And then it happens in the eyes. And that's why diabetes is a leading cause for blindness and also for end-stage kidney disease. And what that does is it connects to them that, oh my gosh, this is why this is so very serious. And unfortunately, many patients haven't had that understanding. And so we have to spend the time to you know, it's why Jesus talked about parables, right? Make it where people can understand and then help them in the behavior to turn it around. And then organizations must find out what the barrier is to that understanding and meet the need so that we can help patients get to better outcomes.
Very good. And I'm glad you said that because this leads us directly into our next question. We're talking about like kidney disease, diabetes, hypertension. Those are some of the primary conditions that we see in our minority communities. But can you explain to us, you and Dr. Hunter, I'll put this out to both of you, how can you explain, or how do you explain, you can have kidney disease and it causes your blood pressure to go up, and then you can have high blood pressure and it can cause kidney damage? Can you explain how that works?
Absolutely. So, and I can start, and Dr. Hunter, you can jump in there as well. But when you think about, I'll start with type 1 diabetes. As I mentioned, you have that excess sugar that goes in your bloodstream, and that sugar sits in the bloodstream, and it causes oxidation. It causes advanced aging or oxidative stress within the kidneys, and that causes function of the kidneys to be damaged. Okay. And then at the same time, when you have higher blood pressure, we know in the minority community, because of diet, we have dietary issues where we have higher sodium diets, and then just from a genetic predisposition to high blood pressure, over time, those in the kidneys, you have the nephrons, which are connected to the capillaries, which are like hair-like blood vessels, the smallest in the body. Once that oxidative stress hits those capillaries, it causes dysfunction in the nephrons, and then therefore that causes problems in kidney function, which then damages the kidney's ability to filter blood. So you have that issue with diabetes. You have that issue also with higher blood pressure causing damage in the kidneys. And so it's a vicious cycle. And that's why we have to do everything that we can to help patients understand, hey, if we can, and also prevention is worth a pound of cure, right? So if we can help you to get back to pre-diabetes, if we help you to lose weight, we know excess weight leads to increased insulin resistance, leading to pre-diabetes, leading to diabetes, thus leading to chronic kidney disease. So if we can help them to prevent that from even occurring, and that's through a good diet, exercise, really trying to reverse some of the effects of just a poor diet and just poor genetics as well, we can help prevent that cycle from even beginning.
Thank you. Dr. Hunter, you have anything you want to contribute?
Sure. I would just add, I'm notorious for not wanting to change the air filters at my house. I'm going to use that analogy, and Dr. Walker knows where I'm going with this. But
oh, yeah.
if you are an individual that likes to wait for the last minute to change your air filters, you know that you start to get a decrease in the flow of clean air. You start to get a problem with the temperature control within your home. And all of these things are because of blockage and cloggage and because of constriction of the air flowing through that filter. The nephrons that Dr. Walker referred to are those filters. Those are the filters that move the blood from the capillaries and from the vasculature through the body and take out all of the toxins and then move clean blood back into the body. So when you look at patients who have high blood pressure, those nephrons are being damaged to the point where they're clogging up, like the air filter has not been changed. At a point, because it's not reversible, you get to the point where you have a completely clogged air filter to where a patient needs dialysis to actually be able to function normally, because all of those nephrons, that their job is mainly to filter out toxins and get electrolytes out of the blood and get them into your urine so that your blood can stay clean and your blood can stay effective at transporting oxygen around the body. That doesn't happen when those nephrons have been continuously damaged. And I would just like add lastly is that we have like a host of medications, because of course you got a couple pharmacists on the line that really address this problem. Once these kidneys get damaged, it activates this system called RAS. And essentially it's these three chemicals that will interact with one another to raise the blood pressure possibly. And when the kidneys are damaged, that release actually causes constriction and more raising of the blood pressure. So that's why patients can have kidney disease, and that secondarily can cause high blood pressure, or patients who have high blood pressure can get chronic kidney disease because, like that air filter, there's continuous damage of those nephrons that then causes you to not be able to filter blood. So it's a vicious cycle, and unfortunately it's something that disproportionately affects our African-American community.
Thank you. Thank you very much. That's a good explanation. So on that, Dr. Hunter, now we mentioned about mental health also being something that's probably not being adequately addressed, but as a specialist in oncology, what do you see with regards to medical mistrust with patients, undergoing treatment, refusing treatment? Because can you kind of speak to that for us?
Oh, definitely. It's a tough thing that I have to deal with on a daily basis, is seeing minority patients refuse life-saving treatment because of medical mistrust and bad experiences that somebody else has had in their family, or misinformation of patients that or other family members giving them misinformation of what happens once they receive treatments. Oncology and cancer is something that pretty much touches everybody on this line at some point. Somebody in their family, a sister, a brother, a mother, a father, somebody is affected by this particular disease state. Millions of Americans, millions of people all around the world are diagnosed at times, are going to be diagnosed at some point in time with cancer. 1 in 8 women will be diagnosed with breast cancer by the end of their life. So it's not like something that is not going to touch every person or somebody in your family. And the big problem that I see is that when you think about oncology, you should think about the clinical trials that have been done. We've really been able to decipher that the African-American patient is not the same as the Caucasian counterpart when we give them the same treatment. So it's not like one size fits all. Like if we do all of these clinical trials and 88% of the patients are white and only 7% or 6% are black, those patients are going to react the same way to the treatment. That small sample size makes it very tough for us to treat patients at times that are minority because we don't have the data to really make an informed decision. So there's 5 things that I'll, kind of conclude this question with, and they're actually strategies to try to help with the clinical trial development that we really need to work on as far as the inequality of patients that are represented in those clinical trials. And the big thing is, I think, looking at clinical trials and trying to set up the sites in underserved communities. They've done numerous amounts of studies and shown that the enrollment rate increases when patients are receiving these experimental therapies in their normal community, as opposed to having to go to a place, for instance, like I practiced at MD Anderson, trained at MD Anderson. That's a much different place than maybe, somebody being treated at Smith Clinic at Harris Health. But that may be where that minority patient is comfortable. So you maybe I'd be able to get them to enroll in that clinical trial if you need them to go way down to MD Anderson. And this, of course, it's very big, it's new, it's nice, it's this and that, but it's not home. So setting up these clinical trials in underserved communities, like where they don't have to travel to an unfamiliar place to enroll, a big part of it. Also, pool of investigators. I've been sent into the patient's room multiple times to talk to them about clinical trials in the attempt for them to see someone who looks like them, give them the information so that they can increase their comfort level of what exactly would happen if they did enroll in a clinical trial. I've been involved with clinical trial enrollment since my fellowship, and I've continued on throughout the whole process, even as a practitioner for the past 12 years. And then the last 2 points that I'll just make is just engaging the community. We have the Community Engagement Corps at Texas Southern that's funded by NIH. I'm very involved with talking to small groups of minority patients that either are cancer survivors or that may be newly diagnosed, giving them information about how does it work if you were to join a clinical trial? How does it benefit? Even if it doesn't necessarily benefit you directly, that information gathered could save lives down the way. So there's all different types of ways where we, as practitioners and our patients, as a community, can help one another. And then finally, I think just providing that support. When you're on clinical trials and when you're on these studies and when you have these patients that are going to get these treatments, them not having continuous support in a standardized way for them to enroll and then continue to get that support from people they're comfortable with is something that's a downfall, I think, of actually those clinical trials getting the enrollment from a minority buy-in that you really want to see.
Thank you. And I know that you've made a lot of progress with the mobile unit that you have going out into these the minority communities. So
Yes.
That's a good step and approach too.
Definitely. I think that the working with local faith leaders here in the greater Houston area, and also working with different type of nonprofit healthcare health agencies to try to get out into the community. And sometimes we need to bring things to our community as opposed to waiting for them to come to us if we really want to make that positive impact to move that line, to move those numbers. Because those numbers come out, and every time, I know as African American women, y'all see that y'all are die at a higher rate than your Caucasian counterparts. Why is this? You get diagnosed at a later stage. All of these negative things that you see. And I think the way that we can combat some of those things is to bring some of the screening and some of the prevention actually to the community instead of maybe waiting for it to come, because maybe they don't want to even know the information they need to help save themselves. And maybe the genetics in the younger patient population is who I like to talk to, because the genetic screening and identifying high-risk patients, that can also save lives. So there's a lot of different ways you can impact the community in a positive way if we can just get out there and really touch them.
And this applies to all areas of healthcare, health
Yes,
disparities,
definitely.
and just trying to take it to the people, if you will. So can you share with us about this cancer moonshot that we hear President Biden talking about?
Sure. So, back in 2016, this is when President Biden was still vice president. It was at the end of the term, essentially, before the regime changed. They actually got through Congress a $1.8 billion funding award that was going to be distributed through the NIH over a 7-year period. So hundreds of millions of dollars were pretty much devoted to the NIH to help to progress the movement and accelerate the scientific discovery of cancer in the United States, which of course affects worldwide because a lot of the treatments that we're using now, they came actually out of this large grant that was spearheaded by the U.S. government. Also, this grant was responsible for fostering great collaboration among all types of practitioners. There was a lot of siloed approaches when it came to cancer research, where the benchtop research was not communicating well with the clinical research. And if this was a private institution, they didn't want to release their information. The industry had a component of it to where the industry and the educational institutions, the better they work together, the more information that we can gather and the better outcomes we're going to see for our patients. And finally, they were looking at improving and sharing of the data. So that goes back to the industry with the academic institutions. The sharing of the data is what has caused all of these large pivotal phase 3 clinical trials to be further pushed forward, and then all of the patients to be affected. So with what you saw with the Moonshot most recently, and this actually was just released, I think, February 2nd, is that President Biden made another announcement saying it was going to be renewed, because actually the last like $180 million was distributed in 2021. So actually the program had technically stopped in 2022, but early in 2022, as you can see on February 2nd, they reignited the program. So now there's going to be more, financial support to help to continue to progress forward with what was already being done over the past 7 years. Now with the new Moonlight initiative, they're looking at reducing the cancer rate by 50% over the next 25 years is one of their two major goals, and then also improving the experience of patients, but not only patients, also the patients' families, as well as those that are surviving with cancer, which that accounts for hundreds of thousands of Americans as well.
So, but so the government is making all of this available, and we know that even within education, we are taking advantage of the health disparities and some of the funding. We're out there trying to get funding and stuff to participate in some of these studies. So we still continue to be faced with, even though the money is there, is again recruiting, trying to still get people involved and to participate in it. So I know that continues to be, I guess, a struggle everywhere. And a lot of that is just bringing about awareness.
Yeah,
So go ahead.
I think it's definitely a challenge. I think that, when you look at the census data with African Americans in the United States, it's 12.4%. But if you look at any pivotal clinical trial that's even been done with the COVID vaccines, I think the past 4 clinical trials that have been published on the Pfizer's vaccine have shown that you have 6.4 to like 9.7% African American participation in those clinical trials. So you have an underrepresentation of African American patients in clinical trials in general, not even limited to just cancer. And that once again causes those disparities to continue on, because then you don't gather the data, then you're not able to find out the things that are different until it's on the market already, and then maybe hundreds of thousands of patients have been negatively affected by that lack of information that we have because we didn't learn it in the clinical trial as we should have. So,
Right. So Ms. Johnson, Ms. Goins, does this fit into your program any kind of way? This new initiative with the Moonshot in providing patient education or whatever, in your servicing the population?
I'll go. Go ahead.
Go ahead, Gwendolyn.
Okay, I was going to say that I like what Dr. Hunter had to say about going out into the community and making sure people are aware of these, because my wheelhouse is under the scope of education and public health education. So I really think that really the challenge for us is for the medical community, and those of us like us on this call and those of us in the medical community, is to really get out there and speak with one voice. Because even though we're talking about medical mistrust, there are some trusted voices. And this is also one of the strategies that we use to align the messages that we're trying to get to the public about public health. We will go and partner with those trusted voices that we know they're listening to. And so I think that if we as the medical community could get on the same page and really speak with one voice about the programs and the things that are coming available, then I think that we will become more of a trusted voice that they are willing to listen to and take advantage of these programs. Go ahead, Paula.
And I'm just going to agree with Gwendolyn and also Dr. Hunter. For the Area Agency on Aging, education is the key for us in educating our older adults and other populations, caregivers that we serve. And you brought up a good point earlier, mental health. There's such a stigma tied to mental health. And that's a service that we provide. As you said, our services are free of charge. But trying to get that stigma away from mental health, which falls back into that medical mistrust. But something that we're also doing is that we're looking at providing health screening and monitoring, which is another service that will be free of charge to target those who are either uninsured or no insurance. And so to help with prevention, but part of that, it all goes back to educating especially our minority communities, and helping them some to dispel some of the myths that's out there. When you talk about, we consider ourselves a trusted partner in the community, and to come out, as Gwendolyn said, with one voice, so that number one, we can educate and get more people vaccinated, but get more people to participate in research so that we feel more comfortable.
Thank you. So, Paula, the age group that you serve, what is it? Did you mention 16? What is it again? 60?
60. We fall under the Old Americans Act, and the Old Americans Act is for people 60 years of age or older.
Okay, 60 plus.
Mm-hmm.
Those of us that have an AARP card, you service those?
You're getting close, but because they give their card at about, I think, 50,
55 or something, yeah.
Yes. But we do also serve caregivers. Now, our caregivers can be of any age. As long as you're taking care of an older adult, we have services that are for our caregivers as well as veterans. We have some other services for veterans also, and people with disabilities of any age.
And I was going to just add that there's no age limit on the services that we provide in education. However, we also do linkage services. So if in our review or listening session or focus group or interview with a potential client, and we see that there's a service need there, we will provide linkage service to link them to the appropriate agency or health department division that will be more appropriate to meet their need. So again, that goes back to, first of all, us working together to even understand what is everybody doing, so that when I do go into the community as a liaison, which is literally my title, I can liaise them with who I need to liaise them with. I can't do that if I'm not connected to you all to even know what you all offer.
Okay, gotcha. That's awesome. Great. Okay, so let's kind of shift this and look at our vaccine hesitancy. So, Dr. Gobina, people have a lot of concerns and they're still hesitant about the vaccine. So, as one of the leading vaccine manufacturers, what do you say to people who feel the vaccine was rushed?
Thank you, Dr. Estes. The big misconception out there is that the vaccine was rushed. However, mRNA technology, it's been around for many, many years. In fact, at Moderna, We've been working on mRNA technology for over 10 years. So it's important to remember that the science was already there. Once SARS-CoV-2 came around, the existing science was used to code for that virus and act effectively against it.
Thank you. So Dr. Zuri, Ms. Dale, can you tell us the difference between when they say something being rushed versus versus funded, something being funded or lack of funding? What does that have to do with, I guess, vaccine manufacturing?
Yes, I can. Dr. Gobina touched on this a bit, and what she said is absolutely true. Is that the vaccines were created with a method that's been in development for years, and that led to companies being able to start vaccine development fairly early in the pandemic. That, coupled with the infectiousness of COVID-19, created the perfect situation. And I think the development of these vaccines speaks to, perfect place, perfect time, perfect scenario. As devastating as COVID-19 has been, the virus and the nature of the virus created a situation that allowed that development. Typically, when we are developing these vaccines, as Dr. Hunter stated, as Dr. Walker stated, is that, there's difficulty recruiting minorities into clinical trials. And this actually has a direct relationship. But because COVID-19 was so infectious, there was no need to wait on anyone to enlist in the trial. The virus was already so widespread. There was a surplus of individuals who were already available in order to participate in some of these trials. So the developers didn't skip any steps. But what they did do was conduct some of them on what we might consider an overlapping schedule. But there were no steps skipped in the development of the vaccine. And so messenger RNA technology does allow a faster approach than the traditional way, and those technologies have been in development for some time. Again, study volunteers, that was not necessarily a problem due to the infectiousness of the vaccine, and there were many people who were just willing to help with the research. Essentially, it was a race. Who can develop a vaccine the fastest? I think what else is not talked about as much is that typically in the development of these vaccines, it's not just the development, but it's also the distribution. And so what the government did is the government footed the bill, not only for the research, but the widespread distribution. So you couple that with the infectiousness of the virus, the technology that we already had, vaccines just were able to begin very early in the process. And we also have to understand that here in the United States, COVID became more of a thing, in 2020, but in fact, it was first detected in 2019. So we're almost at this point, 3 years post the first detection of the virus. And so by the time those vaccines were manufactured and they came out, there had been research being undergone some time. And so when we talk about vaccine development, we talk about the fact that they were not rushed. Instead, they were funded because the government decided to invest a ton of resources in their development, both in research and in widespread distribution. And if we tie this back to vaccine hesitancy, we know, though, that this does play a large role in the reason why a lot of individuals have been hesitant to take the vaccine. Because they do believe that the vaccines were rushed or the vaccines were not properly developed. They don't understand that even when you look at common vaccines, right? The MMR vaccine, for an example, there were more individuals enlisted in the trials for the COVID-19 vaccine than even MMR vaccines. And those are the vaccines that virtually everybody has taken. We look at the efficacy of a COVID-19 vaccine, the efficacy of the vaccines are actually higher than that of the flu vaccine. But these are things that people don't really know, they don't understand. It's new. There's a learning curve, and we know that we cannot oversimplify the issue of vaccination hesitancy. So we just have to be willing to inform. These are the facts as stated. Again, the vaccines are much more higher efficacy levels than common vaccines that we take. And there were quite a number of individuals who enlisted in the trials, although we do know that there are disparities in the minority individuals that participated due to, as we stated, hesitancy with vaccines.
Okay. So the funding part is instead of the pharmaceutical companies footing the bill because of the severity of it, the government stepped in to provide the funding,
Right.
be the
Absolutely.
funding source.
Perfect.
Okay.
Exactly.
So within the vaccine, and this is to Pam and Zuri, you can chime in as well. People are concerned about what's in the vaccine, about the ingredients in it. They're coming up with a host of things that they're saying that's in it, and again, why they refuse to get the vaccine. So can you tell us about the ingredients that's found in the vaccine? What is or what's not there?
Yes, of course. So what is in the vaccine is, as we all know, mRNA. That mRNA is encapsulated in a lipid nanoparticle. So pretty much it's a kind of like a stabilizing or a protective shell of the mRNA, because mRNA by itself is quite unstable. There's also some buffers and some sucrose in there, but I think it's very important to note what's not in the vaccine. And so there's no aluminum, there are no antibiotics, there are no preservatives, and there's no animal or human tissues, including fetal tissue or neonatal cells or anything of that nature. Also, there's no natural rubber latex in the vial stopper itself.
Okay, thank you. And I think that has been a lot of controversy, people saying that, about the animal and human tissue that's in it, and therefore, they don't want to take it as well.
I think too, the other thing to note is that with those ingredients that she stated, our cells break down the mRNA and that spike protein fairly quickly. So within a few days after being vaccinated, your body is going to naturally break down even those substances. So it's not as if these substances remain in the body for long periods of time. I think another myth that's directly related to that is, are these vaccines able to alter your DNA? Biologically speaking, the nucleus does have a nuclear membrane that's very selective about what is able to enter that nuclear area. And so I would say biologically, it's impossible for the vaccine to alter your DNA because it does not have that access via the nuclear membrane that the nucleus has.
Thank you for sharing that. So I think another one of the concerns is that if people are still susceptible to COVID even after being vaccinated, so why is it important to get the vaccine?
I want to answer this question because this is a question I answer just about every day. This is an answer that I just have off the top of my, it's like even a part of my elevator pitch at this point.
Okay.
But I want to, while we're on the topic of vaccination hesitancy and we're talking about a history of medical mistrust, I would be remiss if we did not mention that it's the unique lived experiences of African Americans that have caused them to develop different perspectives. So while we hear a lot of, well, the vaccine does this and this and this, a lot of that is rooted in the fact that as slaves, many African Americans were not afforded the opportunity to see healthcare providers at all. Times did change, and African Americans were introduced to the Institute of Medicine as we know it today. However, there are still disparities in access, and that disparity in access results in disparity in education. And we talked about the 40-year Tuskegee study, for example, that serves probably among minority communities one of the primary, if not singular, reasons for distrust in medicine, even though that we know that there are numerous examples of that. And it is things such as that has resulted in the feelings of ill intention and disdain, even for participation in clinical trials, to the point of Dr. Hunter. And so I want to say that first, because it's more so this long-standing rooted history that contributes to vaccine hesitancy, because many minorities think that vaccine acceptance is akin to agreeing to be an experimental subject. So we first have to say, okay, so I want to name the fact that these hesitancies are not necessarily unfounded, in that we must be somewhat sensitive to the root of some of these concerns. Now, from an epigenetic standpoint, the reason that we still get vaccinated is because we measure the effectiveness of a vaccine not by its ability to not produce disease, but by its ability to minimize severe infection. or severe, complications from having contracted said disease. When we do that, a natural byproduct is a reduction in transmission. The COVID-19 vaccine is actually not the first vaccine of its type. Polio is a great example of a vaccine that did not prevent infection, but what it did do was prevent severe disease. And we know that the polio vaccine led to it being eradicated. So just because it does not necessarily prevent infection does not mean that the vaccine does not work. The reason that we get vaccinated is because we want to create a situation in which there are less susceptible hosts. Viruses are unable to infect without a host. We currently are serving as the host for these viruses. And if we eliminate the hosts, we eliminate a situation in which viruses are able to infect. We also minimize the opportunity for mutations. You know, the more individuals that we see or that we have that are not vaccinated, the more of an opportunity for mutations and variants to arise that we create. And so it's still important for us to get the vaccine. Of course, we want to minimize severe complications. And the reason that that is a big one is because if we look at data from a Pfizer family study that was done, I was looking at some data that suggested that African Americans were disproportionately hospitalized due to not being vaccinated than their non-minority counterparts. So we look directly at the data. The data shows that non-vaccinated individuals overwhelmingly filled the hospital rooms. And if we look at even that subgroup of people, African American or minority communities made up the vast majority of them.
That's a lot of great information. And I think that's probably it. People are looking at the vaccine to eradicate the disease once and for all, and not realizing that vaccines themselves are really there to minimize the complications that's caused by the disease. So there, and again, that's education. People
now, I will say, because I know that rightfully so, with guidance continuing to change, you know, with things seeming as if they're always changing, I do still understand why there would be some hesitancy or feelings of inconsistency. When we look at the Delta variant, the vaccine actually did a better job of preventing infection, okay? When we look at these vaccines, the characteristics of the spike protein that allowed the vaccine to bind to our host cells, the vaccine's actually did a better job at preventing that binding to our host cells. What we saw in the mutation with Omicron, though, is that the vaccine did not prevent or did not as well prevent that binding to our cells as it did with the Delta variant. So it is true that to some degree, depending upon the variant, depending upon the strain that we are dealing with, you will see less infection. But in the case of Omicron, that particular mutation just led to a characteristic that just did not do that. Instead, what we saw was increased transmissibility, but we saw milder infection. So it is reasonable that individuals will not quite understand what is the value. But if you compare the Delta to the Omicron, we saw it is quite true that the vaccines, that the 2 doses of the vaccines were more effective at neutralizing the Delta than the Omicron. And what research shows now is that a 3rd dose, which is your booster, has higher neutralizing capability than does the 2 doses. So it's not a far-fetched, assumption or assertion, but it is our responsibility to educate. And as science changes, we have to be willing to change and educate as those things.
And I think the general public, as scientists, you're seeing this on a continuous basis because you're in it. And the public is just hearing about it and basically being told to do this, do that, or whatever. And lives are feeling, like being tossed about, whatever. And so it's like, okay, let's just stop it.
Right.
No, I don't want to do anything else anymore. I'll take a risk, take my chances, and because I'm just tired of dealing with it. So I know you talk about, and you can you kind of share this, but data-driven versus perception-driven.
Yes. COVID-19 is a disease of fact. You have COVID or you do not. You know, we have caused it to be a disease of perception and what I think and what I feel. But it is a disease of facts. When we analyze in the lab, we are looking for specific regions. Do we see them? Do we not? Are we detected? Are we not detected? Are we inconclusive? It's a disease of fact. And I think that we have kind of made it be a disease of perception. But I am seeing some shifts, you know, in that. And I think that even the guidance from the CDC is moving a bit that way, with the way in which we have altered isolation and quarantine periods for the vaccinated versus the unvaccinated. So we're doing our best to kind of move with the times. But it's important that we know that if you are positive for the virus that causes COVID-19 or you are not, it's not about opinion. It is a disease of fact, not one of perception.
Awesome. Thank you for explaining that. So now I guess part of one of the new things that we're hearing now is about the mask. And of course, you know, people are refusing to do it, but now they're telling us that the surgical mask, the NK95, are now supposed to be more effective than the cloth mask. So can you provide some information about it, the NK, because now you...
Yeah. I think that this is another one of those examples of where it might seem as if there were some inconsistencies in the messaging, when in fact there were not. You know, K95 and the N95 mask has always been the preferred choice. However, any mask is better than no mask. And so numerous studies sought out to determine the efficacy of, you know, a regular surgical mask versus a cloth mask versus double masking versus some of these masks with higher filtration, such as the KN95 mask or the N95 mask. However, but they have always been the mask of choice. I think with the increased transmissibility of the Omicron, though, I think that CDC just decided to take a stance and say, this is now the preferred option. Whereas it really always has been. It's just that originally we were in a situation where any mask was better than no mask at all. And I think we see another example of that in the way in which we spoke about COVID-19. I think one of the gaps is that originally COVID-19 was presented as a disease that majorly impacted the immunocompromised and the elderly. But that really wasn't the case. It was presented that way because at that time, that is where the priority lied, even though the entire time we knew that the virus could infect anybody. So when you make these changes or seeming changes, it almost appears as if, or you're inconsistent and you don't know what you're talking about. And the last time you said this, but I think a lot of it had to do with resource allocation and priority. The KN95 or the N95 masks were not as readily available at first, just like the COVID tests weren't, just like the vaccines weren't. And so there was a hierarchy of priority, even though those masks were always the preferred ones. And now we're existing in a surplus. The government is actually giving them away. You can very easily get a K95 or N95 mask, and I can drop in the chat those links to get those KN95 masks and those rapid tests that the government is now giving away for free. And we know just 2 weeks ago, you could not walk into a CVS or Walgreens and even get a rapid test, and now we're giving them away. So things change and we just change with it, but I'll drop those things in the chat.
Okay, that'll be good. So Pam and Zuri, so are we looking at an annual COVID vaccine?
Unfortunately, at the moment, we don't have enough data to make that determination. But like Dr. Dale mentioned, after the 2 doses, we saw some waning immunity, and then you needed that booster to come back up to the appropriate levels. So we just have to watch the data and see what happens. But at the moment, we don't have enough information for that. Make a recommendation on that.
All right, so stay tuned, huh? Stay tuned.
Pretty
All
much,
right.
yes.
So a lot of this we have talked about research participation and research participation that's geared toward minorities, which is lacking. And we know that All of Us is a research initiative that's trying to get more populations included in research. I thought that I would have Dr. Kitzman on so that she could kind of speak to this some, but and I guess Gwen, I know that you're involved, Paula, you're involved. So can you explain to us, and maybe even Miguel, if you want to come back too, and maybe you can explain to us what the All of Us research program is, how will it benefit minority communities, knowing, the historical mistrust that we talked about this evening. Can you share that
Sure.
information?
Sure, I can take the first two. So what the All of Us research program is, it is an initiative that's sponsored by the National Institute of Health to include people of color inside a huge resource or medical research database. So basically, when the Modernas and the Pfizers and the Johnson Johnsons of the world start to create medicines or make medications for disease, basically they're using data from middle-aged white men by and large. And so what All of Us seeks to do is we want people of color to go ahead and become a part of this database so that if you are a person of color and you have diabetes or you have a particular medical history, you're willing to create a profile within the All of Us database so that as different research is being and different medications are being developed, your background, nothing about you identifies you specifically, but just those medical records for a person of color can also be considered in that research. And so I work with the Black Greek Letter Consortium as one of the partners of the All of Us program. And so the benefit is that this is precision medicine. So we've been talking about medical mistrust, and you mentioned earlier the Tuskegee experiments. And so, what precision medicine means is that now if I go to the doctor and all of a sudden you have 1 million people, that's the goal, to get 1 million people in this database whose backgrounds are more similar than mine. And I tell my physician what I have and what's going on with me. Now they have a database of people of color that they can kind of more closely align what might be going on with me rather than just the cookie cutter, one size fits all type of approach to medicine. So that's basically what All of Us is. And so we have partners all across the nation that are working with this initiative. Like I said, I sit on the Black Greek Letter Consortium. Each of the Divine Nine or the historically Black Greek Letter organizations has 3 members on that team. And our goal is to, while we work together, but we work within our organizations to get this information out. We have right now going on something called Rooted in Resilience, where we're going to different cities. Just like the saying says, all politics is local. And so basically, whenever we come up with these new programs or new initiatives, people want to know, what is this? What's in it for me? What does this mean for me specifically? So Rooted in Resilience basically means that those fraternities and sororities are going to go into those cities and they're going to have small group conversations and explain what All of Us is and get people to sign up on the spot. And so I think I've covered what the research program is and how it benefits us. It just gets us closer to that precision medicine part of our medical diagnosis.
So is there any incentive for signing up?
Well, yeah, I guess the incentive is more intrinsic one, just knowing that it may not be your generation that is helped, but it might be the generation to come. It might be things that are going to help your children or your children's children as these new medicines are being developed that are more closely aligned to people who look like you. It may not necessarily be you specifically that are helped, but it might be your child, your niece, your nephew, your grandbaby that it is actually benefited the most by the program.
So Paula, do you or Miguel, do you have anything to add about the AOU, how to participate in it?
Yeah, no, pretty much agreeing with everything that Wendell said. Again, this could help pretty much anybody that signs up for a program, and future generations, how different things like environment, lifestyle, and genes, could definitely make an impact on their health, and also help develop new medical treatments that are unique, for each person.
And I would just say, for me, it's always the key is the precision medicine. I always like to use when we're out doing speaking engagements is something that Gwen pointed to, is that if you take, and I always just compare two people, if I take myself and I take Gwendolyn, I live in a rural area, she lives in the urban area. We both have been diagnosed, for example, with diabetes, but she has access to things that I don't have. She has a walking path. She doesn't live in a food desert. She has access to education, whereas I don't have those things. And so by creating this database allows the providers to be able to pull out those things that are closer and more aligned to us. And therefore, I should not get the same treatment that Gwendolyn is getting because I don't have the same access. And so that's what usually resonates. I think that's just like I love that example. And that's how we utilize it, and to help get the word out and to educate others about, as Gwendolyn said, based on who participates in research, we need to increase looking at diversity and inclusion in the research field.
And I dropped some links in the chat. One of them is All of Us Sash Together link, where anybody can just go and look on that website to see, just read all about it. If you put All of Us on YouTube, there's a plethora of videos. Most of them are just a couple of minutes long, and that will really help explain the program and the initiative and what we're trying to do. And then I also went ahead and dropped in there the COVID information link. We've been talking about medical mistrust and access and vaccine hesitancy. And that is really something that people should familiarize themselves, the resources that are within the city. If you go to that page, it has all of the resources that you ever wanted to know, and some that you probably didn't, about COVID, where to get tested, where to get vaccines, how to request a speaker, if you want someone to come and talk to your church or your group or even your family about any questions that you may have. This is all a part of that, us reaching out and becoming that trusted voice that we talked about, so that we can hear their concerns, have that personal listening session, and then be able to create those linkage services for what they need specifically for that particular family.
Good, thank you.
The only other thing I would say, once they read the website, is that you can participate as much as you want to participate. That's a good thing about the initiative also. And so do the research to know about the research is what I say.
Very good. Good. All right, well, thank you. Those are all of the questions that I have for our panel, and we will move to the chat. So I think that we have covered a lot of information by first defining what medical mistrust is, looking at some of the history as to why medical mistrust exists. And we know that medical mistrust leads to poor outcomes within the minority community. And that has carried over from our regular health disparities in diabetes, hypertension, and other comorbid conditions. But now we're looking at this even in the face of COVID, which is the new culprit, if you will, that's on the scene. And so mistrust continues to carry forward in it. One of the things that will benefit us overall, and as Gwen mentioned, even though participating in AOU, All of Us research program, may not benefit us directly now, but it may benefit, you know, those of us in the future, our loved ones that's in the future. Education, we know it is key that we be informed and make informed decisions. But this is something within the minority communities that, you know, we're going to have to, I guess, step out on faith and, you know, learn to trust God in these decisions about participating in clinical trials and even signing up just for AOU. As it mentioned, this is something where you're just sharing your current condition, your current medical condition, and things that are about you. So they're not, there's not where they're gonna, you're not sharing, I guess, specific information with regards to who you are, where you live, that somebody's gonna come hunt you down, track you down. You're just sharing this information within a database so that any researcher that's doing research in specific areas now have a database that they can go and pull information from as they continue to do research in those particular areas. So instead of now doing a recruitment, and some of you may have seen this done, you know, throughout, that X, Y, and Z is recruiting for people to participate in this. I'm not saying that that won't continue, but the AOU program is a database that will store already that information that researchers can now pull from. So did I explain that sufficiently, Gwen, Paula?
Yes, I was going to say that was really good, and thank you for mentioning that. There is a very, they have painstakingly made sure that your records and what you share is protected. Your privacy is protected. And there is a very stringent process in place to even be a part of the people who can access that information. And so I believe there's different levels. So there's a very, even just to get on just a basic level, just to get information, you know, basic data, there's a stringent process to do that. So you can feel very confident that if you participate in this program, your information is protected. The program has been going on, I want to say, is it 4 years or 5 years, Paula? I think the goal was to have 1 million people in 10 years. And there have been, I want to say, 0 security breaches with regard to that database. So people can feel very confident that their information is secure.
Yeah, great, thank you. And even your physician, they don't have access to your records. It's secure. Nobody can get into it, can just, you know, willy-nilly, if you will, get access to that information. So they have safeguards and things in place to make sure that your health information, that it is protected. So the link is in the chat, so you can copy that link and go to it and find more information about it. Right now, we're going to move real quickly to the chat to try to address any questions and things that we may have from the chat. So Aaron, are there any questions that you've observed in the chat that you can share?
So we have a few. The first question is, would the panel be willing to go into some of the communities where you know the mistrust is deep and explain why we really need to take the vaccine? Some people really need to hear the pros from the people that look like us or them.
Okay. And I think a lot of this was mentioned. Gwen talked about how they go into, that they have a program and that they actually go into the community, and maybe someone else was talking about it, Dr. Hunter as well. So any of the panel, you want to address this question?
I'll speak. Let me speak first from the perspective of what TSU is doing. Not completely understanding that we can do much more. So given the COVID climate, a lot of these conversations and talks have been similar to the format that we have now, these virtual conversations. I know TSU has hosted 2 COVID conversations. We also have created social media kits, because what we're trying to do is establish Texas Southern University as one of the premier institutions by which you would come to receive your COVID information. Just like people know that Johns Hopkins is a public health institution, we are trying to establish TSU as a leader in COVID response. So we do try to host these conversations. We have gone out into the community and conducted some vaccination hesitancy surveys. Very early on last year, we did some vaccination hesitancy work at the CUNY homes, where we tried to determine what are some of the limiting factors and some of the reasons that individuals opt not to vaccinate. We do have a weekly segment on KTSU radio station to expand our reach, because we want to make sure that the community remains educated. We send out a weekly COVID info notice, but we recognize that with a lot of that, it's internal. You know, when we are asked to get out into the community, we do so, but I do think that we need to do a better job of self-identifying some of these areas and being intentional about reaching out to partnering organizations. The NAACP recently reached out to us about coming and doing some talks, but Texas Southern does need to do better about kind of getting out into the community. So we are willing to do that, but I think that for a lot of us, the climate of COVID has just prevented us from getting out into the community as much as we might have wanted to. So if there are any opportunities, particularly for TSU, if any organization or if any groups or anything want to invite us to come speak, we're more than willing to do that in the mode that you all request.
Dr. Estes, also I wanted to add to that I think it's imperative that we get out into the community and meet them where they are. One of the things that the All of Us research program actually did in the city of Dallas was conducted at one of the largest churches in the city of Dallas, Pastor Frederick Haynes Church. We did a showing of the movie, The Immortal Life of Henrietta Lacks. And I actually was one of the hosts. Dr. Kitzman was on the stage. We had another individual, I believe, from SMU University that was also on the panel. And before the actual showing of the movie, we answered questions, and afterwards we had questions and we did a panel, and it was nicely attended. And it was one of those sessions that really worked to create a bridge and promote healing and have a very open conversation where we talked about the Tuskegee experiment. We talked about the impact that them actually beginning to see research as partnering with them to help in preventing negative health outcomes would have. And I think that the more we do those types of things, along with what Dr. Zuri just mentioned, I think we're going to do a great job at creating a bridge in our communities.
I would also like to add that the Houston Health Department, actually, we have a bureau, a speakers bureau that actually will come out and do presentations about COVID, about the vaccines. And so I'm going to put my email address in the chat, but we also have peer ambassadors so that we can send more people out into the community and to do those presentations. And so I'm happy to move you to the person who, actually her name is Tia Johnson, who's actually heading up that area.
Thank you. So anything else, Karen?
Another question that we have is it safe to say that the COVID-19 situation is now an endemic and under control? If yes, when can we take off the mask?
I think that endemic is not the way we would probably describe where we are just yet. I'm not certain that, and I see Dr. Walker and Dr. Gobina agreeing with me. I'm not certain that we're endemic yet. I think that what we see is a lessening of cases. what we see is a lessening of hospitalizations. It does not necessarily mean that the vaccine, that the virus is endemic just yet. And even though cases are low relative to what they were, there are still a considerable number of people being impacted by the virus that causes COVID-19. So I'm not certain that masking and or lifting masking restrictions are the way to go just yet. But I can say that I would not, and perhaps Dr. Gobina and Dr. Walker can weigh in on whether or not you believe the virus to be endemic at this point.
I completely agree with Dr. Dale. I wouldn't call it that at this point. And of course, we always recommend follow CDC guidelines, and we don't recommend, but it's always recommended to follow the CDC guidelines and go with what they're mentioning at this point or recommending at this point. So, but I agree with Dr. Dale. I don't think we're at endemic state yet.
Dr. Walker, you're muted.
I would absolutely agree with what they've stated. I lean on the side of caution in everything, and I think that we become way too lax. And so thankfully, the variants seem to be lessening in severity in terms of the new variants. And so certainly we're thankful for that. But I think it's far too early to just take your guard completely down. And so hopefully we won't see another more severe variant come out. I've heard nothing. I don't know if Dr. Dale or Dr. Gobina have heard anything, but I think that, you know, it is worth us continuing to be cautious and vigilant and encouraging large crowds. I mean, I'm still one that, hey, I'll keep a mask on, you know. And then in addition to that as well, I mean, you know, we also have to think about we're in the flu time as well, and you're seeing individuals with the flu combined with Omicron, you know, and just sort of thinking about that as well. I've actually seen some people who've suffered from that as well. So certainly we want to just stay vigilant as much as possible.
Thank you. So Aaron, anything else?
Okay. What would you tell a student where to start on how to help encourage everyone to get vaccinated despite Omicron being less fatal?
Vaccination conversations are ones that have to be approached with a level of sensitivity. I'll say that first. There are some courses, actually, free courses that you can take, and I'll drop that in the chat, about how you can approach some vaccination conversations and even become somewhat of a certified vaccination ambassador, and I will drop those. But I think that if you approach these conversations with the facts and not just about what you think, it tends to help me have these conversations a bit easier. I normally approach the conversations about why be vaccinated from the standpoint of vaccines are not designed to prevent infection. We do not measure vaccines by their ability to prevent you from getting sick. We measure them by their ability to prevent you from contracting severe illness. That is plainly stated. That is fact. Whether it's the COVID-19 vaccine, the flu vaccine, that's just vaccines in general. And I find that if you address the facts, it makes some of those conversations be a bit easier. Now, I will say that I've been in conversations with people where they do not want the facts. You give them all the facts, and then they dispute the facts with opinion, and that is going to happen. But my advice is that you, for one, take one of those cultural sensitivity trainings first, and then you learn the facts so that you can present those facts as they are in order to combat some of that hesitancy. And I'll be honest and say that I participated in a lot of conversations like this, and a large number of people have left saying, I feel better now. I understand better now. So we don't want to make the assumption that people don't want to know. And we also do not want to make the assumption that people don't want to do what's best for themselves. And I think a lot of times we make that assumption in minority communities. We need to give people the information. So if they opt to not get vaccinated, they are able to make a conscious decision. The decision to not get vaccinated, there's absolutely nothing wrong with not being vaccinated. If a person opts that vaccination is not for them, that is a personal decision or choice that they have made. But by giving them the facts, we give them options. Now they are making a decision that is rooted in some sort of science. And if they still opt not to do it, they opt not to do it. It's still a personal decision that they're making for themselves.
And that is exactly the approach we take with Office of Chronic Disease. When we go out into the community, when we're doing canvassing events or taking information, and a lot of it is we try not to approach it where we're here to convince you to get the vaccine. We're here to give you the information so that you can make the best decision for you and your families, and to be myth busters when we can. But you have to, it's a fine line. You don't ever want to be so confrontational that, you're just dogged with it. You have to know when to walk away and, save room for another conversation for another day. Always leave it where you can come back. I was always taught, never, be careful how you leave a job. You never know, life may take a turn. You may have to go back there. But so just remember, they're citizens, they're people just like you. And that's the approach. If you don't go in it with, I got to convince them that they've got to take the vaccine, approach it, hey, I'm here to provide information and to listen. And, I want to help you make the best decision for your family. And if that's not your decision today, okay. Now, do you have any questions about what I've said? Is there anything that still mystifies you about the process or about anything? So be fact barriers of truth and share that and love and understanding, and then come back another day if you need to visit again.
Very well stated. Very well. Okay. I think we still have time.
Okay, so this question is directed to Dr. Dale. Do you think the cases being lower are due to people being vaccinated and social distancing? And what do you think about the new quarantine rules?
So I think that the lower cases that we see right now, particularly with Omicron, is a combination of being vaccinated and the vast number of people who contracted the virus. Between November and January, many people contracted Omicron. And just when we look at the epigenetics of a virus in generally viruses are going to give you some degree of innate immunity after contraction if we look at the way other viruses of this same family operate. And so we probably have a couple of months where people have some degree of natural immunity. And what research shows is that if you have contracted COVID and you are vaccinated, your immunity is even more boosted than if you only contracted COVID versus only being vaccinated. So that combination of both gives you some decent, longer standing immunity than if you had contracted any of them individually. Now, regarding the quarantine rules, from my perspective, and I think anyone can weigh in on this, I'm not certain. We'll say this. In theory, a disease or a virus that is less severe is going to result in an infection period that is lesser than a virus that might be more severe. So in theory, it would seem as if shortening the isolation period might be appropriate, because the period of infectiousness might be shorter. However, there is some contention that the shortening of the isolation period was due to some of the social impacts of the virus and getting people back to work and that sort of thing. I know particularly for the TSU community and the research and the daily data that we monitor, what we see is that at day 5, individuals are overwhelmingly continuing to test positive. Does not mean that they are necessarily still infectious, but we are seeing that individuals are continuing to test positive. And I think a gap is that one thing that we did not do in the United States is caveat that with after 5 days, you can exit with a negative test. Whereas the UK took the extra step to say, okay, we'll take it down to 5 days, but it's 5 days in the negative test, not just 5 days and then a mask for an additional 5 days. So particularly at TSU, we've been careful about not lessening the threshold of exposure. We have kept our isolation period at 10 days. That is what we have opted to do at Texas Southern University, just out of an abundance of caution. We also have to consider the demographic that we serve. We do serve a demographic that is disproportionately impacted by other health incomes, the incidence of asthma in our community, the incidence of some of those comorbidities. And so what we didn't want to do is bring people back too prematurely. But I think that the drop in cases that we see right now is just a lot of people caught it with this Omicron. Many people caught it. Omicron very quickly became the dominant strain. And so that, coupled with the vaccinations, has helped. I think that social distancing has dropped a bit lower on the mitigation strategy list. I'm not sure that places are putting as much emphasis on the social distancing as they once were, whereas vaccination is probably considered now to be a top mitigation strategy along with appropriate masks.
Thank you. All right.
Okay, and our final question is, how do we get a nutritional diet for kidney or hypertension patients through Ms. Gwen's program?
I am going to drop a link in the chat so that you basically just complete this form, and then just say what program you're interested in, and someone will contact you and get that information to you. Did you get it? You do it again. Okay.
GoHealthyHouston.org.
Then / contact us. That's the form. The GoHealthyHouston.org is the main page with all the programming, but the contact us gets you the form that you fill out online, and it shoots us an email, and then just tell us what program you're interested in, and it's our diabetes and wellness network will get back in touch with you.
Good.
And I'm going to, if you don't hear anything, I'll go ahead and put my email directly so that if you don't hear back, feel free to email me directly.
Okay. And we don't want to forget our poll. So if we could put our survey also in the chat, and we ask that each of you, if you take a minute or so to complete our post survey or poll questions that we have. Kind of capture some of the demographics of the participants that have been on the call with us today would be great. Thank you, Ms. Johnson. So you see the link there. If you just take a minute, click on that, fill out the form for us, would be good. And so while you are doing that, I just want to say thank you to all of our panel guests that was with us this evening. And when I reached out to them, nobody turned me down. Everybody, graciously agreed to participate in tonight's event. And I really do appreciate that. If I share my screen, will they still be able to see the chat? This is the contact information for our speakers. If there was someone that you're particularly interested in maybe reaching out to, this is their email address. If you want to jot that information down, please feel free to do so. And also, I would like to thank our community partners. Ms. Jessica Walker, who's the Director of Community Wellness Solutions. She's with the Community Council of Greater Dallas, the Dallas Area Agency on Aging. Thank you to she and her team, Patricia Johnson and Miguel Trejo, who was on with us this evening. Thank you for partnering with us and bringing this opportunity to TSU to be able to share to our community and to our students. And also, I want to thank Ms. Cynthia Johnson. She's the Director of Administration in the College of Pharmacy and Health Sciences. She actually helped to market our program. She's providing tech support. So she has been an instrumental part of planning this activity, and my thanks go out to her tremendously. And also to my research assistant, she's Erin Payne Green. She is a PharmD candidate of 2024. She's a P2 student, and she's doing research participation with me. And thank you. She really was excited about us being able to offer this event, as we have viewed other presentations regarding AOU. And again, we were happy to be able to provide this to our students and to our community. And actually, she was the one that created our slideshow for us this evening of our presenters that you're watching. So thank you, Erin, for your enthusiasm and for being with us, participating in this event as well. So has everyone been able to get the link? Are there any comments from any of our speakers?
Yeah, I do have one. As I was kind of just scanning through the chat, I saw actually one of our students, on our PharmD students, was referring to the Latin community and how it's related to the African American community when you talk about minority research and minorities in general, and you do see a low amount of representation. It's a lot harder to pinpoint it because of the way the questionnaires are set up. And I think that's what's challenging, because with a lot of the clinical trials, like a Latin patient is going to be, a Latino patient is going to be under a white patient. So it's going to look like they're white, but maybe not all of those patients are traditionally Caucasian patients. There could be Latino patients that are mixed in. So there's a challenge there to be able to identify them. Sometimes the trials, the questionnaires will get as they'll have of Hispanic descent. So if you say you're white, it'll say, are you Hispanic or you not non-Hispanic? And you'll be able to gather more information. But I think the trials are actually, it's a bit of a challenge to be able to pinpoint that type of patient, because they are grouped into the white population. But yeah, it's a good thought, because they actually have different activities and different things that they do. Socioeconomic backgrounds are different than what you would expect maybe with their Caucasian or majority counterpart as well. So definitely disparities exist there also.
I think one of the problems with the Hispanic, though, is also, and most people today don't realize, that the segregation only affected African Americans. Hispanics were not treated separately until we got into the 60s and the 70s, when African Americans started. So there's not a lot of historical information about the treatment of Hispanics, because, as you said, they were treated as white, but they were not also displaced from the main American society the way that African Americans were displaced during desegregation.
Thank you, Dr. Douglas, for that historical perspective. Didn't realize that. That's good information.
Yeah, because if you look at, let's take Rice University, for instance, Hispanics could always attend Rice University. It was just African Americans who couldn't attend Rice University. And that's the way you don't, and let's take Houston. There were no Hispanic public schools in Houston. There were just black schools and white schools. Blacks went to one school, whites, Asians, Hispanics, foreigners, everybody else went to a different school. So race in America was against discrimination against African Americans, not against anybody else.
All right, well, thank you for sharing that information. And now as we move on, though, those minority, what we consider to be minority communities now still are facing those same health challenges, you know, that we see in the African American community. And that was part of the target of our conversation. You know, we were looking at minority communities, especially African Americans. As we know, we have a rich history of medical mistrust. But we also were inclusive of other minority communities that are, because of the health disparities, of being part of this conversation as well. So if,
Dr. Estes, I wanted to say thank you so much for hosting. You did a phenomenal job on this evening. Thank you also for the invitation. It's always an honor to come back to my alma mater, proud Texas Southern University Tiger and graduate. And Dr. Hunter, you sound like Dr. Mo, man. I can tell Dr. Mo, you had some Dr. Mo in your background, man. So I enjoyed this evening. Thank you, guys.
well, thank you.
Dr. Estes, I want to resonate with what Dr. Walker said. I have the same feelings. Thank you so much for inviting us. This is an excellent panel. Just honored to be here amongst so many great leaders in the community and experts. And so thank you for putting this together and for allowing us to be here.
Thank you for attending. I appreciate that very much. Thank you. So with that being said, if we have no other questions in the chat or any comments, I think this will wrap up our program for the evening. Please, 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 if you haven't done so, please complete the poll questions that was submitted in the chat. If you would take a minute to do that, it will be greatly appreciated. And with that being said, I wish you a good evening and thank you again for your participation. Be safe and be well.